Thank you. So we'll move on to the last theme of this session, which is clinical translation. And this is going to be a virtual talk from Crispin Hiley, who's based at UCL, and he's going to tell us about opportunities for clinical translation. Thank you, Crispin, if you're there.
Hi there. Thanks. I can't start my video, but I shall start talking. Right, I think that should be working now. Okay, hopefully you can all see my screen. So I'd just like to thank the organisers for inviting me to give a presentation today. So my name is Crispin Hiley, and I'm a clinical academic in the City of London RadNet unit, and I'm a clinical oncologist who cares for patients with lung cancer. I wanted to talk today about opportunities for clinical translation within the City of London RadNet unit. And I think the great benefit of the City of London unit is that there's 3 clinical sites, so Guy's and St Thomas's, Bart and UCLH, and there's a large number of research active clinicians who are keen to collaborate with translational and basic scientists. So the message really is that please do reach out to them if you're looking for collaborators, and if you don't know who to reach out to, please do get in touch with myself or with obviously with Maria Hawkins, who's the clinical lead, and we'll try to facilitate interactions. So what I wanted to talk about today was to highlight the aims of the clinical translation theme and to highlight a few examples of projects that are ongoing, and this is somewhat focused on the things that I'm more directly involved with, so this is not an exhaustive list by any means, but I wanted to talk about a study called CVERT, which we're setting up, which is a prospective cohort study to apply an evolutionary perspective to radiation resistance. We have a peace study radiotherapy cohort. This is an national autopsy study, which I'll talk about. And we're also trying to leverage ctDNA assays to study radiation resistance. So the original aims of the clinical translation themes was really to have efficient forward and reverse translation with all themes. And we're facilitating this with interactions across the unit with symposiums such as this, but also a lot of other interactions behind the scenes. We wanted to develop a radiation-based tissue and data resource. Anisha Mystery, who will talk later, is coordinating the City of London RadNet Biobank, and we'll talk about this in the closed session. We're also interested in new cohorts of patients who could be potential targets for drug combination studies, and I think some of the talks already have alluded to what those cohorts might look like. And also, obviously, we would, Simon mentioned earlier, developing a RadNet Trials Hub, and this is empowered really by, particularly with interactions with the UCL Clinical Trials unit, and obviously quite focused on proton therapy and proton therapy trials. So CVERT is a study that is currently in setup, and it's studying tumour and microenvironment evolution following external beam radiation therapy. For those who don't get the acronym, CVERT is a measure of radiation absorbed dose, and it's a prospective observational cohort study in which translational research is the fundamental aspect of the study. We aim to apply an evolutionary lens to radiation resistance in order to understand the biology of treatment failure. We'll focus on both residual disease in the setting of neoadjuvant chemoradiotherapy, as well as recurrent disease following radical radiotherapy. And the primary endpoint is to identify the proportion of monoclonal versus polyclonal relapses following radical radiotherapy or chemoradiotherapy, as we think that this is actually quite an important thing to ascertain to help guide consolidation and salvage therapies following radiation. And we're going to apply some of the sort of genomic tissue phenotyping and analysis tools that we have within the City of London Centre. I'd really just like to already thank all the clinicians across GSTT, UCLH and BART who've given us lots of feedback about feasibility when we approached them and some helpful input. I'd like to thank the patient representatives who've also given us some feedback about how important they feel this study might be for patients having radiotherapy. And I'd particularly like to thank Kitty Chan and Laura Fowley at the UCL Clinical Trials Unit, who are really critical for helping to move this forward. So the target population is non-small cell lung cancer patients and esophageal cancer patients having neoadjuvant chemoradiotherapy prior to surgery. We do quite a lot of esophageal cancer neoadjuvant therapy, not so much for non-small cell lung cancer, but I think the NICE guidance suggests we probably should do more. But also, obviously, we'd like to look at patients who've relapsed following radical radiotherapy, and so collecting biopsies from patients who've relapsed following treatment for lung cancer and esophageal cancer, and also for patients with GBM who are having sort of debulking following radical radiotherapy. And hopefully that might help to look at, answer some of the questions that Anthony Sharma raised about relapse within the field versus infiltration from sort of areas such as the subventricular zone. So the targeted accrual for this study, and initially we just want to see how feasible it is to collect samples from these patients. So aiming for 50 patients in the first 18 months. And then if feasible, we'd expand to a larger number for lung cancer, esophageal cancer and GBM. The recruiting sites at the moment are the clinical sites within the City of London RadNet unit, but we would really like to expand this across the RadNet network, and I think it's actually critical that we do if we're going to achieve those sorts of recruitment numbers. So I'll be very interested to hear from anyone who's on the call today about how interested they would be to collaborate in this prospective study. I just wanted to highlight some of the translational samples we would like to collect. The caveat, obviously, to all of this is that the analysis will be dependent on external grant funding, but we'll be collecting tissue, and I think it's important to do whole genome sequencing given the sort of structural variants that can occur following radiation. We can apply tissue cytoff, which for those who don't know is a sort of highly multiplexed form of immunohistochemistry effectively, so that you can analyze sort of 30, 40 different biomarkers in a single 4-micron section. So we can really analyze the tissue tumor microenvironment. We'd like to look at exosomes, which are a sort of extracellular vesicles which have been implicated in cell-to-cell communication. And we'll do this in collaboration with Professor Tony Young at KCL. Look at ctDNA and clonal dynamics with bespoke libraries, which I'll come on to talk about in a few slides. We'd like to leverage some of the information that we've gained looking at sort of neoantigen reactive T-cell phenotypes and dysfunction in early lung cancer and apply this to the radiation setting by looking at PBMCs that we collect from these patients. And also we'll aim to collect whole blood RNA that would allow us to look at T-cell receptor repertoire sequencing and other elements within the RNA. Sort of in tandem with this, there is something called the PEACE study, which many of you may have heard of, which is a pan-cancer national research autopsy program. This is led by Mariam Jamal Hajani and obviously also Charlie Swanton. And the objective of this study is to study cancer evolution and the tumor microenvironment at the time of death, and to take a multi-omics approach to understanding the processes involved in metastatic disease and treatment failure. I'm pleased to say that earlier this year we were given approval by the PEACE Trial Steering Committee to open a cohort specifically focused on patients who've received radical radiotherapy at some point during their treatment. And again, we're focused at the moment on lung cancer, GBM, and esophageal cancer. And at the moment, we're at UCLH, we're approaching patients who would like to, patients that would like to take this opportunity. I'd also like to take this opportunity to highlight this this cohort to, again, other centres within RadNet. Obviously, these, as this is a sort of a post-mortem tissue sampling, we're able to do much more comprehensive sampling of disease. So we'll be able to look at in-field recurrence as well as out-of-field metastases, and I think importantly be able to look at normal tissue toxicity in the brain, but also particularly in the cardiac tissue, which I think has been shown to be very important, and lung tissue. So PEACE sites at the moment, the open PEACE sites are UCLH, the Christie Hospital, Royal Marsden Hospital, Birmingham and Leicester. And there's pretty good overlap, as you can see, with the RadNet sites, with the City of London, Manchester, ICR. Obviously, unfortunately, there's no PEACE cohorts located close to Cambridge, Leeds, Glasgow or Oxford, but it doesn't exclude patients being referred in if they have a particular desire to participate in this study. So again, I've alluded to the tumour types that we're including, and be patients who've received radical radiotherapy at some point in their previous lines of therapy. And ideally, if patients have some form of longitudinal sampling, either they have a previous biopsy, either from a clinical trial or a local biobank, that would allow us to add a sort of longitudinal aspect to these studies. The process, well, patients are approached by clinicians in appropriate time. They can be consented. Consent can be performed after death, but normally it's before that time. And if it's been useful to akin it to organ donation for patients, and they found that a useful parallel. We can consent remotely, which has been really important during COVID, and it's ideal to have the families involved. The local undertaker who are contracted for this study will arrange transfer of the patient from the hospital or home after death from wherever they are in the regional area, and sampling is performed very quickly, so there's no delay to funeral arrangements. So if people would think this is something they could collaborate with us on, please do get in touch. And then I'd really just like to finish by talking about circulating biomarkers. So Nisha Mistry, who's pictured here, is the RadNet Biobank tissue coordinator and collector. And so we're collecting plasma samples for ctDNA analysis within that biobank, but we have a UCLH, we have a prospective study called RAIL, which was set up by Ed Chandy, a fellow of mine, in collaboration with Jamie McClelland and Maria Hawkins. And this study actually is looking at the implementation of a deep learning algorithm to quantify radiation-induced lung changes, and it's been REC approved. But we're also collecting along this study cfDNA collection during treatments and at follow-up and progression. And hopefully this is actually something in terms of the ctDNA collection we hope to expand upon and collaborate with the Manchester RadNet unit with Corin Favafin and Ahmed Salam. So the aim of this work really is to leverage an additional technique already established by the TracerX team, published in Nature in 2017, where bespoke ctDNA libraries were developed, allowing you to perform really high depth sequencing to track tumor clones over time. Obviously, the problem that we have in the locally advanced setting is that often we have limited tissue from a biopsy, unlike in the TracerX study where they had multi-region sequencing of resected lung cancer. So the schema that we'd like to apply is what's called ultra low pass whole genome sequencing of the baseline sample. We'd use this to identify patient samples that have a high fraction of ctDNA, and in those we'd be able to perform whole exome sequencing on the plasma and use that to pick variants to make bespoke ctDNA libraries, tracking a large number of variants. And this last slide really is just an example of how powerful this approach can be. So this is an example of tracking variants in a patient who had squamous cell carcinoma from surgical resection through to metastatic disease and disease progression. So you can see the thick pink line is the sort of clonal variants that were tracked, and you can see during the treatment in the metastatic setting, it looks like a fairly sort of stable disease. But if you look at the thinner lines, which represent all the different subclones within this patient's ctDNA, you can see actually there's really quite a varied response to different treatments, with some clones being quite sensitive and other clones being quite resistant. And it's really this sort of resolution that we'd like to apply to radiation resistance, certainly in lung cancer, which is where we're collecting samples at the moment. But potentially we'd like to open this platform up to other tumor types. So in summary, it's really exciting to see this sort of symposium come together. There's a lot of engaged clinicians across the City of London RadNet unit with an interest in translation. We have a really great ability to leverage existing translational platforms across the different partner institutions. I've talked about some of these prospective studies that I'm involved in to investigate radiation resistance, both in terms of the cell intrinsic and the tumor microenvironment perspective. And I've mentioned about leveraging ctDNA platforms. Due to the issues of the time, I haven't talked about organoids, but we have Jayant Rain, who's an NIHR funded academic clinical fellow, who'll be working with Brian Dirkstraße, who's a postdoc in Charlie Swanson's lab, to help develop organoids and transitioning these organoid platforms to allow us to study radiation resistance. And with that, I'd like to thank you all for your attention, and I'm happy to take any questions.
Thank you, Crispin. In the interest of time, if we've got one quick question, then we can take that. If not, if you could address your questions to Crispin, and obviously if you're interested in collaborating with him, please get in touch.